All right, so today we're going to go through two little lectures. So diabetes, right? It's basically ions because we're going to look at diabetes and glucose, and then sodium and potassium and how that gets balanced out. So first, this lecture on diabetes. So let's start with glucose levels, right? We know that insulin has many effects on the cells of the body. It's first released from the beta cells of the pancreas, right? We know that glucose stimulates beta cells to release insulin. And so when blood glucose rise, right, then we release a lot more of this insulin. And we know that insulin triggers glucose absorption in insulin dependent cells, right? So we have more absorption of the glucose in those cells that depend on insulin. Insulin also triggers other things, right? It's not just about the glucose. So it triggers amino acid absorption, inhibits lipolysis, proteolysis, right? So the breaking of fats and proteins, glycogenolysis, breaking glycogen, because you want to store it. You want to store glucose, right? And also gluconeogenesis, right? Because you don't want to make new glucose, you have enough. And it triggers lipogenesis. Lipo means fat, genesis means producing it. So you're triggering the production of fat because you have a lot of glucose, you have a lot of nutrients to store, right? So glucose levels, right? A large portion of dietary glucose enters our skeletal muscles and adipose tissue. So that blood glucose goes to our skeletal muscle and our adipose tissue. So in skeletal muscle, we replenish our glycogen storages. In our fats, we build fat, right, in these adipocytes. And in your liver, we actually absorb glucose to rebuild the glycogen, right, but also to build fat. You could, if there's enough glycogen, then you'll build fat. And all the cells of your body use glucose to perform cellular respiration, right? This glucose also goes everywhere else where it was needed. Every other cell needs glucose as well. So some common signs and symptoms, right? So glucose levels, we could have normal glycemic levels. They're defined as fasting plasma glucose. In your plasma, you'll measure that glucose, FPG. So if FPG levels are below 6.0 millimolar per liter, then that's normal. Impaired fasting glucose, right? So this IFG levels, they're defined as fasting plasma glucose levels, right? So this is when you have these levels that are between 6.1 and 6.9 millimolar per liter, then this indicates a pre-diabetic state, okay? Now, a FPG level that's above 7 millimolars per liter, this indicates diabetes for sure. The oral glucose tolerance test, right, that measures glucose levels 2 hours after administering 75 grams of glucose solution, could be used to understand how those glucose levels are, right? So hyperglycemia, right, is responsible for symptoms of diabetes, right? Blurred vision, fatigue, these different paresthesias and skin infections, right? So blurred vision results from hyperosmotic fluids, humors and blood, right, in the eye, causing crenation of the cells, right? There's too much of these glucose molecules and it's sucking out the water because water moves by osmosis. Fatigue results from lower plasma levels due to frequent urination, right? Paresthesia results from the temporary dysfunction of peripheral nerves due to osmotic imbalance. Because water is moving around trying to balance out the glucose, right? Then we have osmotic balances in nerves, so this could happen. And skin infections result from elevated levels of glucose in sweat and excretions, right? So the three polys, we call them, so along with hyperglycemia, there are three polys that accompany diabetes, right? And it kind of linked to what we talked about. There's polyuria, polydipsia, and this polyphagia, right? So polyuria results from the body trying to eliminate excess glucose via urine, right? And glucose pulling water out of the tissue. Polydipsia, right, results from excessive production of urine. This is production as opposed to trying to eliminate, right? So triggering the thirst reflex, right? This is your thirst. And polyphagia results from the lack of satiation from eating due to the body's inability to absorb glucose from food and breaking down fats and proteins. So you're not satiated, you're not you're still hungry, right? Even though you ate. Polyphagia, right, specifically, is more common in type 1 diabetes as insulin deficiency is absolute, right? You don't have any insulin at all. So there's an inability of adipocytes to absorb the glucose, which prevents the release of this leptin, which is a hormone that triggers satiety, meaning it's a hormone that tells you, okay, I'm full, I don't need more food. Weight loss, despite this polyphagia, occurs in type 1 diabetes, right? And it results from the loss of body fluids, polyuria and emesis, right? And breaking down of fat and protein. So polyphagia, right, is less common in type 2 diabetes because insulin resistance is not absolute. You do have some insulin, it's just not responding to the insulin, right? There's some response to the insulin that remains. So how do we test for this? We do urine tests, but now we don't really do it anymore. It's not really necessary as more reliable tests are available. So monitoring of blood glucose occurs via capillary blood glucose monitoring, right? But how is this diagnosed? There are 4 common tests that we use, okay? So the first one is called fasting blood glucose test. This occurs as food is withheld for 8 hours and glucose levels are monitored. If ever you know someone who's done this before, the doctor or the person that's doing the blood test will ask the patient not to eat, right, for 8 hours before. So at night you stop eating. And so then we see how much glucose is there, right? Glucose levels below 6.0 millimolar per liter are normal. Glucose levels between 6.1 and 6.9 millimolar per liter indicate impairment, and glucose levels above 7 millimolar per liter suggest diabetes, okay? So this is a fasting blood glucose because you're measuring the glucose when there was nothing consumed, right? You were fasting for 8 hours. The random blood glucose test disregards time but is performed on a patient if they show additional symptoms of diabetes. So glucose levels above 11 millimolar per liter suggests diabetes, right? If there's this random test during the day. And then there's the oral glucose tolerance test, right? So this postprandial measure of blood glucose after the administration of this standardized solution. So what is asked of the patient? You're going to ask the patient to drink this special glucose solution with a specific amount. So actually you're going to fast, right? And then you're going to take this gross solution and drink it. And then they're going to see how you're metabolizing this glucose and is it getting out of your bloodstream, right? So in patients without diabetes, blood glucose returns to normal in 2 to 3 hours after the solution is taken. So you could take a blood test 2 hours later and see how much glucose is there. If it's still a lot, then probably diabetes. And the last one is to look at this glycated hemoglobin testing measure. So this is hemoglobin, right? And you have these glycosylations. I don't know if you see them in green. You have these little glucoses that are all around this hemoglobin. And these little, basically you're measuring that via the hemoglobin, right? So glucose in blood can irreversibly and non-enzymatically attach itself to hemoglobin. So glucose binds onto hemoglobin. I know we're not used to thinking of this, it's always oxygen, but there are glycosylations on the hemoglobin. And since the lifespan of a red blood cell is about 120 days, right, the glycosylated hemoglobin provides a reliable snapshot of the last 3 months, right? Think of it, it's so finicky to measure glucose just like that in the blood. You need to ask the patient to fast and then not to do anything, and then they take the test. Whereas this is more of a long-term snapshot, and we don't need to worry about did the patient actually go and take glucose, right? So this is another measure of that. So since erythrocytes are independent, right? They don't need it. We can measure the levels of glycosylated hemoglobin called HbA1c. So hemoglobin A1c, this is a version of them, and it occurs as a percentage. Okay, so a recording of more than 7% of these HbA that are glycosylated suggest unmanaged diabetes. Other tests could be can monitor the presence of autoantibodies, like those against glutamic acid decarboxylase, which is an enzyme, tyrosine phosphatase IA, right, and insulin. So if this is an autoimmune thing, right, then we can find these little antibodies that are bad and that are destroying the pancreatic cells, right? So if it's an autoimmune condition, then we would want to test antibodies. So hallmarks of diabetes, right? Type 1 diabetes is an absolute insulin deficiency. You're not making any insulin, right? So hyperglycemia occurs as skeletal muscles and adipose tissue cannot absorb glucose, right? The little dependent receptors that need insulin to take it up are not taking it up anymore. Without insulin, gluconeogenesis, lipolysis, and elevated ketone production occurs during the fed state. So when you eat glucose and your skeletal muscle can take it up, right? And adipose tissue can take it up. Instead, what happens is your body takes these glucoses and undergoes gluconeogenesis, where they take this glucose and will either convert it. They're using it for other products. Lipolysis too, right? And elevated ketone production all occur in the fed state. So a variety of available energy sources can cause ketosis, right? If you have all of this, you're going to make so many ketone bodies, right? You're going to end up using it to make amino acids, right? You're going to use the glucose to make these fatty acids and glycerol. And all these excess ketone bodies, right, will create what we call this metabolic acidosis, right? Because ketone bodies are very acidic. So as ketones use is outpaced by their production, ketoacidosis can proceed. In type 2 diabetes, hyperglycemia with insulin resistance, right? It's not that we don't have any insulin. It's that we're resisting it because we don't want to listen to it anymore. And we get this relative insulin deficiency. So levels may be low, normal, or high. It depends where you are progressed in this type 2 diabetes. The risk factors, obesity, right, and poor nutrition throughout life, and physical inactivity will be a high disposition for this type 2 diabetes. Insulin resistance leads to overproduction of insulin by the beta cells, okay? So because you're resisting, right, the pancreas is saying, nobody's listening, so it's trying to make more and more insulin. And this leads to beta cells being exhausted and eventually failure of them, right? So insulin resistance actually precedes insulin deficiency, right? So it's a progressive disease. Type 2 diabetes worsens as the following occurs. As insulin resistance progresses, skeletal muscle, adipocytes, and hepatocytes become less sensitive to the insulin, and hyperglycemia causes beta cells to produce more and more insulin. So you're making deranged insulin release, right, more and more. And a decrease in insulin sensitivity occurs as cells decrease the number of insulin receptors on their surface. These little receptors that are on the skeletal muscle, that are on this liver, they're not wanting to respond to that anymore, right? This is a normal negative feedback loop. Oh, I feel like I'm picking up too much of the signal. I'll tell it to shut down and not really be super sensitive to this signal, right? This is called a down regulation. So in the liver, insulin is less able to inhibit this gluconeogenesis, right? In the hepatocytes, we're not able to inhibit gluconeogenesis as much. So we'll be making, these new glucoses. Now, insulin deficiency progresses, right? Beta cell destruction progresses. More and more of those beta cells break down. Ketone production rises, right? But ketoacidosis remains rare because the insulin deficiency is not absolute. We don't have full disregard of the insulin. There's still little response. So without insulin, the liver increases glucose production, right? As gluconeogenesis is normally inhibited by insulin, this is not good because we're still going to be making these new glucose molecules. And then the prandial glucose contributes to hyperglycemia. But that glucose production from the liver, right, starts becoming a major contributor. Then the liver starts being the problem. So it's really a never-ending loop. Insulin, so let's talk about this metabolic syndrome, right? Insulin resistance and deficiency cause, in addition, a metabolic syndrome because adipocytes, right, these fat cells, break down their stores and you start getting this increase in fatty acids, right? Hepatocytes continue lipogenesis, right? They continue making these fats and causing an increase in plasma triglycerides. You have lower levels of HDL, and hypertension is this comorbidity, starts influencing these microvascular and macrovascular diseases. So this is a never-ending loop of just all these systems are overdoing the wrong thing, and you get what we call a metabolic syndrome, right? Things are not doing what they're supposed to. And eventually you get this systemic inflammation and abnormal fibrinolysis, right? That starts occurring because you start inflammating all these places that are not doing the right thing, and it starts getting really bad. The risks for type 2 diabetes, obesity and physical inactivity are the most common risk factors. But remember, we talked about these multifactorial inheritance types, right? Type 2 diabetes also has genetic factors. Some people have genes that are more likely for this. So there's really, two factors that affect it. So another risk factor is fat storage, where you store it, right? So in the upper body and around the abdominal pelvic organs presents the strongest links with the disease, okay? So the truth is this cause of death for the beta cell destruction, we don't really understand why the body is doing this. So as adipocytes absorb less glucose, right? Maybe it's because they start releasing this less of this hormone over here, right? Adiponectin hormone, a hormone that increases the sensitivity of our body cells to insulin, right? We're thinking maybe it might be this. And elevated fatty acids in the blood, right, from adipose and liver appear to be inhibiting the glucose uptake by the cells of the body, while the overactive beta cells, right, they release amylin, leading to beta amyloid deposits alongside this insulin. Excessive fatty acids and beta amyloid appear to be toxic to those beta cells, right? And then less adiponectin progresses and insulin insensitivity. And more of those fatty acids and beta amyloids cause that insulin deficiency. This is just a little hypothesis. So secondary diabetes mellitus, this is described as hyperglycemia resulting from other conditions and syndromes, right? You might get this diabetes like hyperglycemia not because of diabetes, not because of necessarily the pancreas and the typical type 1 and type 2, but it could be because of other syndromes, okay? So for example, pancreatic and endocrine diseases, right? In these cases, hyperglycemia is caused by a decrease in glucose utilization by the cells and an increased glucose production by the liver, okay? For example, in Cushing's syndrome, okay, this is an endocrine system syndrome, the body is exposed to elevated levels of glucocorticoids, which are glucose-sparing steroid hormones, right? They want to keep the glucose. And thiazidides and loop diuretics increase urination frequency and associated potassium loss, impairing insulin production by the beta cells. So this is another example where you could have insulin production by the beta cells that's impaired, but it's not because of diabetes per se, right? It's these other syndromes that are affecting it. Gestational diabetes is also another example. So hyperglycemia during pregnancy occurs 4 to 18% of all pregnancies. So risk factors include a family history of diabetes, history of stillbirth, right? Fetal abnormalities in previous pregnancies, previous large or heavy for date infants, right? Bigger babies. Maternal obesity as well as a risk factor, advanced maternal age, and 5 or more pregnancies really make this more likely. So even mild hyperglycemia can be dangerous to the fetus, right? So, and they can increase gestational complications and fetal mortality and abnormalities. So that's why, there's always these follow-ups to make sure that things are okay during the pregnancy. Mothers with diabetes, they just go for a few more follow-ups to make sure that the levels are okay, and the physicians can properly balance out doses of certain things if they think that it might be elevated or too low. So an oral glucose tolerance test should be completed immediately to diagnose this gestational diabetes and repeated within 24 to 28 weeks. Treatment include nutritional management during the pregnancy to maintain normal glycemic levels and possible exogenous insulin injections, right? So that things stay as is. Type 1 diabetes treatments, let's talk about on the upside, the treatments. Since insulin deficiency is absolute, we have no insulin at all being produced. Insulin injections are required, right? So type of insulin used will depend on the patient's preferences, right? Affordability and propensity, of course. Lispro and aspart, right, are rapid acting and commonly used during meals. So this prandial insulin. And then these two drugs here, this glargine and this detamir over here, are long acting and will cover insulin needs for actually an entire day. In type 2 diabetes, right, improving insulin sensitivity, right, because you need to make those cells be more sensitive. And you're going to want to treat those metabolic disorders. Those are your goals, right? So metformin is an anti-diabetic medication, and we use it to treat that insulin sensitivity, while A1C measurements are used to observe improvements if things are going well. Additional anti-diabetic medications may be used to ensure that the A1C remains below the 7%. If A1C remains higher than 9.5%, then insulin should be administered as complete beta cell destruction has likely occurred, right? So the effects of insulin, right? We have a few. Insulin triggers 4 major events in the body upon its secretion. Promotes glucose uptake for cell respiration and glycogenesis, prevents fat and glycogen breakdown, and it inhibits gluconeogenesis, and it increases this protein synthesis, okay? So characteristics of insulin, the molecule. Insulin, it's this peptide hormone composed of 2 chains, an A and a B chain, and it's synthesized in an inactive form called this proinsulin. This forms is packaged inside vesicles and cleaved into its active form called insulin. During this cleavage, we have a connecting peptide. We call it the C peptide that is produced. It is released alongside active insulin, right? So that C peptide level can be monitored to evaluate beta cell functioning, okay, as it remains in the blood longer than the insulin. So that C peptide is a good marker, actually, to see, to evaluate the beta cell functioning. Insulin release. GLUT2 is a glucose transporter 2. This is present on your beta cells of the pancreas and hepatocytes of the liver. It has a low affinity for glucose, right? Not too strong. It doesn't want glucose too much, just a little bit. And being insulin independent, right? Exogenous glucose that came from outside that we ingested enters the beta cells and triggers insulin release, right? Insulin makes its way into the circulation and binds the insulin receptors on the surface of a few places, right? Skeletal muscle, cardiac muscle, and adipose cells. This triggers the translocation of the GLUT4 on the surface of these cells to allow glucose absorption. So first, insulin binds, right? First of all, it gets released by the pancreas. It binds. It tells these GLUT4s, right, to put those receptors up on the membrane, and then glucose is allowed to transport through these skeletal muscles or cardiac muscle or adipose cells, right? There are other insulin-independent cells of the body that use types of GLUTs, other GLUT types that remain on the plasma membrane, right? Renal cells in the kidney along the nephron, erythrocytes, and gastric epithelial cells use GLUT1. Cells of the brain and peripheral nerve cells use GLUT3, okay? So, okay, now we're going to start with water balance, right? And ions as well, right? Sodium and potassium, and how this could affect the body. So first of all, water balance, right? Water movement, water moves between compartments. We call these compartments of the body. You have the ECF, right? This extracellular fluid, which is everything that's outside of the cells, right? So outside of this cell, the interstitial space, and over here, the plasma, right? All of that is ECF. And intracellular fluid, right? ICF. This inside of the cell is called the ICF. There's fluid there, right? And so water moves between these because there are certain osmotic forces that are at play, right? Remember, ions cause water to move into places that have ions that cannot move, right? So large movements of water between these compartments, right, is actually uncommon, right? There shouldn't be too much movement. There should be a good balance. When capillary hydrostatic pressure, right, and colloid pressure are altered, then filtration and reabsorption across the capillaries are impacted, right? So if you aren't too sure about these terms, make sure you look at the pre-lecture material. The capillary hydrostatic pressure is basically the blood pressure, the pressure from the heart, how much it's pushing, right? And the colloid pressure over here is created by the little proteins that are in the concentration of those proteins that we have. So filtration and reabsorption of fluids are impacted by these two pressures. The majority of our water is in our cells, 70% is ICF, and in the ECF, water moves freely across the capillaries between the interstitial fluid, in purple here, which is about 80% of the ECF, and our plasma, which is about 20% of the ECF, right? Water movement. So, smaller shifts in water movement between the ECF and the ICF occur when osmotic pressures are altered, right? When we have differences in osmotic pressure, then that's when we get these shifts, and blood pressure remains unaltered, right? If water loss occurs without electrolyte loss, right? If we lose water and we don't lose the ions in it as well, then we have a loss, right? It starts losing the water and it starts becoming hypertonicity of the ECF, because there's a lot more ions on the outside in the ECF, right? Compared to the water, right? And then this causes water to move from the ICF inside the cell to the ECF outside because it's trying to rebalance that change. If water gain occurs without electrolyte loss, let's say you drink a lot of water, pure water, okay, then this might create a hypotonic solution, right, of the ECF because there'll be a lot less ions on the outside, which will cause water to move from the ECF on the outside to the ICF, right, in, because it's trying to maintain that balance. And here's what we were looking at before, right? Intracellular fluid, we have a lot of. We have some interstitial fluid and plasma. These two are your ECF, right? So, water movement. Let's talk about small changes, right? Small changes in water. Osmoreceptors in the hypothalamus over here in the brain are sensitive to these small 1 to 2% changes in water volume or osmolarity, right? These have small effects on ADH levels, antidiuretic hormone levels, right? They're not going to really change much, this hormone. Let's talk about it in a bit. So these osmoreceptors, they're not going to really have an endocrine effect. Baroreceptors, right, can sense these small changes and adjust your blood pressure by influencing cardiac output. So when you have small changes, your blood pressure is going to make small little tweaks thanks to the baroreceptors that could sense these small changes. In the event of large water volume changes, right, that exceed the compensatory capacity of the heart, right, if the heart can't do these small little changes, right, then baroreceptors in the carotid and aortic sinus can trigger further changes. Over here, right, you have in the carotid and the aortic arch, you have these little baroreceptors, right, that'll send nerves, right, the vagus nerve here and cranial nerve 9 over here, right, you're going to send that up and you're going to trigger the release of greater amounts of ADH, antidiuretic hormone, along with aldosterone, right? If you're not too sure about these, go look in the pre-lecture material as well. Antidiuretic hormone, it says it in its name, antidiarrhea. In diarrhea, you have a lot of water leaving your body, so antidiuretic hormone wants to keep that water in your body, right? And aldosterone is its partner also that helps out with all this. So this happens for big water losses, okay? We're going to talk about, in the following slides, we'll examine small changes in water volume though. So hypertonicity of the ECF. This can occur during episodes of excessive perspiration. You're sweating a lot, right? You know this. When you sweat a lot, start getting dizzy a bit, or you could be a bit thirstier, right? And inadequate water intake, right? If you don't drink enough, you're not putting enough water, and the solutes, sodium and potassium, are getting concentrated. If you sweat a lot, then same thing, you're releasing a lot of water, but not the solutes, right? The salts, the sodium and potassium. So this could cause hypernatremia, too much sodium, and this could cause water to move into the ECF from the ICF, right? Because you just got this hypertonicity in the extracellular fluid. Osmoreceptors in neurons of the hypothalamus sense these changes and trigger ADH release from the posterior pituitary if it gets really bad, right? And if it's severe enough, it could cause a decrease in blood volume and a decrease in blood pressure and maybe even shock, right? So the treatment, how you treat this is you'd give hypotonic fluids orally or intravenously. In a hypotonicity situation of the ECF, right, when you have, think of it, this means that you have a lot of water on the outside of the cells, but you don't have much solutes. This can occur during hyperhydration if you drink too much water, right, and with vomiting and diarrhea, because you equally release water and also ions. You have a large increase in water intake or retention without a corresponding increase in electrolytes, right? In those sodium and potassiums. So water moves from the ECF into the ICF, right? Because, again, you had this low amount of solutes outside. This inhibits the antidiuretic hormone, the ADH secretion, and you're going to decrease thirst and increase water excretion from the kidneys, okay? And so that hyperhydration can occur during kidney failure, heart failure, cirrhosis, or endocrine dysfunctions. We're going to see this one, this endocrine condition over here. Hypotonicity of the ECF, right? The first major change in hyperhydration, you're going to get this hyponatremia, right? We see noticeable effects on the central nervous system, a lot of confusion, hallucinations, convulsions, coma, and severe cases, death. The treatment is diuretics, right? You're going to give some diuretics and intravenous hypertonic saline solutions. So let's talk about diabetes and dysnatremias, right? In diabetes, we say that it's diabetes-induced natremias, right? Because it's the diabetes that caused it. Hyperglycemia causes this hypertonicity and dysregulation of sodium plasma content. Here, this was the normal ECF and ICF, right? All of a sudden, in the ECF, you have this excess of glucose, which allows water to move into the ECF, right? And so you start getting this change in this sodium, right? And you start getting this different hyponatremia. So hyperglycemia causes H2O movement, as I said, from the ICF into the ECF. You see it moving this way, right? Resulting in a hypertonic hyponatremia. This is coupled with osmotic diuresis and polyuria, right? Excessive fluid loss and ALD, this aldosterone stimulation. And if fluids are not adequately replaced, this can cause hypertonic hypernatremia. These conditions often result from unmanaged diabetes, and care must be taken when rehydrating patients to consider that sodium level. Now, edema. Let's take a little pause from this, hypernatremia and stuff. I want us to understand what edema is. Edema is fluid accumulation in these tissues. So it's caused by fluid accumulation in the interstitial space, right? So we're going to see over here in this interstitial space, when blood gets filtered through the capillaries, right, then we get edema. And there's a few ways you could get edema. First, if you have an increase in capillary filtration, that means that your arterial blood pressure, right, you're pushing all these ions through the little pores. So that over here is increased capillary filtration. We also have a decrease in colloid pressure, right? Let's say you have liver disease and you have no more of certain liver proteins, right? Big proteins like albumins or globulins, then you're going to have a decreased colloid pressure. Increased capillary permeability, right? If your capillaries start becoming more and more loosey-goosey, then that blood is going to filter through. And lymphatic obstruction. Here are the lymph nodes, the lymph vessels. If these are obstructed, then you can't circulate all of that liquid that's being pushed out. Again, if this isn't making too much sense, go back to the pre-lecture notes. This was some stuff from the previous courses on kind of that capillary exchange, okay? So let's go through them one by one. Increased capillary filtration, right? This occurs with increases in arterial pressure or venous pressure. So you have, in my picture here, you have more and more of this arterial pressure, right? So a high blood pressure or venous pressure, as this will increase the filtration across the capillaries, right? Here you have you have a high pressure that's pushing water out, right, into this interstitial fluid. As this will increase filtration across the capillaries. Edema is localized when inflammatory or allergic compounds, maybe histamines, could dilate those arterioles or those precapillary sphincters. Edema could also be generalized, right? So when there's an increase in, let's say, some vascular volume. So for example, the right-sided heart failure could cause edema in lower extremities, right? Due to that heart failure. Decreased colloid pressure, right? So this was a different situation. I was telling you that this usually results from an albumin loss. So during liver failure, right? Or maybe it could be starvation or malnutrition if you're not getting the right amino acids, or maybe even kidney disease, right? So liver failure results in less albumin produced. Starvation and malnutrition results in fewer amino acids available to make the albumin. And kidney disease, let's say glomerular nephritis, that'll cause the glomeruli to be more permeable to plasma proteins and you'll pee them out, okay? Albumin could also be lost from areas of damaged skin. Let's say a burn victim, right? That could really just cause edema there. That's why when you have a burn, sometimes you'll see this pouch of liquid on top of it, right? You get some edema there due to that loss in that region. Alrighty. The third thing was increased capillary permeability. Maybe my cells, you see them here, the black dots lines here, they're a little more spaced out, right? They might be a little more loosey-goosey. So this occurs when the capillary endothelium is damaged, which could cause plasma proteins to move into the tissues, right? This can occur during, as I said, burn injuries with inflammation and immune responses, right? All of these could cause that. And the last thing is lymphatic obstruction, right? Here's my little blood vessel, and here's my lymph node, okay? The lymphatic system, the whole point of it is to return excess fluids and solutes and to not allow it to be reabsorbed by the capillaries, right? If it can't get reabsorbed back, then it'll put it back into venous circulation. Obstruction of this flow, this lymphatic flow, can occur in lymphatic vessels and lymph nodes, right? So for example, there's certain cancers where they'll remove the lymph nodes, right? Or maybe during infections, this could cause an obstruction. Edema caused in this way is called lymphedema because the lymph nodes are the reason. Some manifestations of edema, right? So edemas are particularly dangerous if they occur in the brain or the lungs. On a tissue level, edema increases the diffusion distance between cells and the capillary supply, altering the availability of respiratory gases and nutrients, right? So edemas can also compress blood vessels. For example, edemas in the digits, in the fingers, right? Edemas in or around joints can limit the range of motion of these joints. So how do we assess and treat these? A finger pressure, right, can be used to assess the degree of edema. If it's more generalized, monitoring of weight of the patient is needed, as water is going to be more retained in the body. Treatment, you can often it'll include elevating these extremities. Wherever you have edema, you'll elevate it, so lifting your leg up, right? Infusion of serum albumin if caused by increased ECF volume, or some kind of diuretic therapy to eliminate these excess fluids. Compression socks are actually very good because it'll increase that interstitial pressure and minimize the filtration across the capillaries, right? So now we move on to electrolyte balances, the sodium one, right? So these influence the ECF and ICF. Electrolytes not only influence water movement, but also cellular function, right? Attention is given to sodium and potassium because they're the major contributors of osmotic concentrations and they'll affect water movement, okay? So NaCl and this sodium over here, this molecule, are major salts, right? That account for 90% of osmotic concentrations in the ECF. Sodium concentrations are about 140 milliequivalents per liter, right? And in the ICF, less than 10. Potassium are 3.5 to 5.5 milliequivalents per liter. In the ICF 160. Of course, when we take blood tests, right, we're thinking of these numbers here. The most common electrolyte imbalances are sodium related, however, but potassium imbalances are less common but more dangerous. Okay, we'll see why. So let's talk about sodium. So the levels are determined by how much we absorb from our diet and excrete from our kidneys and in our sweat. Okay, so changes in sodium, really that content in the ECF do not result in changes in concentration, right? People think that there'll be big concentration changes. Water will actually move to maintain it. This is osmosis, right? Sodium is not going to move. Water is going to move, okay? So consequently, large changes in sodium content are needed to produce an observable pathological response, right? So without the appropriate water intake, hypernatremia, hyper means a lot, of natremia sodium. Na is the first letter of natremia, and Na is the element on the periodic table for sodium. Hypernatremia causes water to move from the ICF to the ECF, right? Hypothalamic osmoreceptors sense this change and triggers the release of antidiuretic hormone. And the thirst reflex, right? What are some potential causes of this? Eating excessive salty food. You know this. When you eat a bag of salt chips, right? Salt and vinegar, you get thirsty after. You want some, right? Because you're putting a bunch of these sodiums in the ECF, and then your body's triggering you to want to go and drink water. Okay, so this is hypertonic, a lot of sodium on the outside. Water will want to move out, right? Here are the body cells, water wants to move out, and the neuron, water wants to move out. During episodes of excessive sweating, as perspiration is hypotonic, right, compared to the ECF, without corresponding hydration. So that's a cause as well. Hyponatremia, as we hydrate during episodes of excessive sweating, all of a sudden, right, hyponatremia could occur if electrolytes are not consumed. So if you just flood the outside with water, then you have low amounts of this sodium on the outside. You never have no sodium, because remember, sodium is very concentrated on the outside of the cell. Water intake increases ECF volume, right? So you start drinking, and then the ECF on the outside starts getting more and more filled with water. Without a corresponding increase in sodium, if you just drink water alone, then you get this hyponatremia and causes water to move from the ECF into the ICF. So when you vomit or have diarrhea, they often suggest that you take Gatorade or something with a bit more salts so that you can balance that out, right? Water might not be the best thing to hydrate you. Antidiuretic hormone secretion is inhibited, and then the thirst reflex is inhibited. So let's talk about sodium content and blood pressure, okay? Because this movement of water does affect the blood pressure. When you have these large fluctuations in sodium levels, this can greatly influence water content in the ECF, right? Which includes the plasma. This is directly linked to that blood volume and blood pressure. So whenever you move things in the ECF, this is gonna go and increase your blood volume, right? So significant decreases in the extracellular fluid volume will decrease the blood volume, right? And decrease blood pressure. That triggers renin-angiotensin-aldosterone system, right? To increase the sodium and increase water retention. You want to stop losing that outer fluid. Significant increases in the ECF volume, right? If I have that situation where I have the water going, I drink a lot of water, right? Just pure water, then you're going to increase your blood volume and increase your blood pressure. This stimulates ANP, this natriuretic peptide hormones, and this will inhibit the renin-angiotensin-aldosterone system so that you increase sodium and increase water excretion, okay? Monitoring your sodium levels. Hypernatremia will occur when sodium levels rise above 145 milliequivalents per liter, okay? This is called hypernatremia. Signs and symptoms include excessive thirst, dry mucous membranes and wrinkles, right? If it's more severe, it could reduce blood volume and blood pressure, and increase your heart rate and eventually create this hypovolemic shock. The treatment for that, you'll give your patient more water or IV infusions of these hypotonic saline solutions. For the hyponatremias, this occurs when the sodium levels fall below 135 milliequivalents per liter. And the signs and symptoms of that is mild, for the mild hyponatremia, you could have headaches, vomiting, nausea, muscle weakness, and cramps. When it's more severe hyponatremia, you'll have CNS dysfunction. So confusion, your patient might feel lethargic, a bit of muscle weakness, maybe some hallucinations, convulsions, and if very severe, a coma, right? Why does this happen? I think it's because you have more of these near the neurons, and so the neurons start to swell and they can't function as normally, right? We finally get to the neuron level and have a bigger effect. So the treatment is diuretics, so that you can get rid of that excess water, or IV infusion of these hypertonic solutions. That was sodium. Let's now look at potassium. So potassium balance, right? Most 98% of the potassium is in the cells. So here it's not very representative. Potassium is usually inside of the cells, right? In the ICF. And it's absorbed from our diet and primarily excreted by the kidneys. Our kidneys will absorb sodium at the expense of potassium, actually, through the sodium-potassium pump. You'll remember the sodium-potassium pump, it'll pump 3 sodiums for every 2 potassium, right? So potassium excretion increases when aldosterone levels are much higher. Our kidneys exchange potassium and hydrogen to adjust the pH of our body fluids, and this occurs via the potassium-hydrogen antiporter, right? This is a transporter. And when large amounts of that potassium is consumed, cells of the body, the red blood cells, the hepatocytes, the muscle cells, they could take up that potassium and avoid hyperkalemia, right? Hyper, a lot, kalemia, potassium, because the first letter of potassium in the periodic table, it's K, right? So hyperkalemia. Why? Remember I told you potassium doesn't really change. Usually we don't have problems with it, but when we do, it's dangerous, right? So why are small shifts in potassium so dangerous? Potassium is used for excitable cells, like neurons and heart cells. They rely on potassium to establish their resting membrane potential, right? The RMP, the resting membrane potential. The resting membrane potential of neurons will decrease during hypokalemia. You see hypokalemia decreases the resting membrane potential, and it increases during hyperkalemia, right? If it's further away from the threshold, neurons are less likely to fire, and that'll cause muscle weakness and different arrhythmias, okay? Now, if it's closer to threshold, neurons fire more easily, and this could cause spasms in different parts and arrhythmias, right? So let's talk about hypokalemia. It's characterized by potassium concentrations that are below 3.5 milliequivalents, and it's caused by low potassium diets. There's no retention mechanisms in kidneys. What are the causes of it? Losses could also occur during traumatic episodes, right? These increase blood pressure and increase aldosterone, damage to the skin, burns or crushing injuries, and also via the GI tract, so vomiting and diarrhea. Some signs and symptoms: muscle weakness, chronically maybe a paralysis, and cardiac arrhythmias, atrial fibrillation, and decreased heart rate, decreased blood pressure. Treatments include dietary potassium intake, which include tablets, and potassium chloride solutions in an IV bag. So hypokalemia most seriously affects the heart, and these effects can be seen in the ECG actually. You have a prolonged PR interval, right? So over here, you see this PR interval is going to be longer. This longer delay between atrial depolarization and ventricular depolarization. And you'll see this bradycardia, right? The U wave formation occurs as ventricles have difficulty repolarizing during ventricular arrhythmias. So you'll actually see this new wave in your ECG called the U wave. And you'll have an inverted T wave that can also occur in these patients. Okay, hyperkalemia now is characterized by potassium concentrations above 5.5 milliequivalents per liter. This causes include chronically low blood pH, so metabolic acidosis, kidney failure, and different medications that promote diuresis by blocking the sodium reabsorption, right? Signs and symptoms include muscle spasms, severe cardiac arrhythmias, cardiac conduction impairment such as VFib, ventricular fibrillation, and or this bradycardia. The treatments include dietary restrictions, selection of appropriate diuretics, or infusion of hypotonic solution, right? Or some appropriate buffer solution if acidosis is related, right? So a few things here. Hyperkalemia most seriously affects the heart, and these effects could be seen on our ECG, right? We could see a low P wave over here and a prolonged PR interval. Also, you'll see this widening of the QRS complex and an increase in the T wave. And so this is indicative of ventricular fibrillation. So last little topic over here, or topic or two. Let's talk about thirst, right? We need to know how we'll actually tell the body to get more of this liquid. Baroreceptors, they're going to stimulate changes in blood volume and blood pressure. The effective circulating volume is the volume of vascular compartments, okay? There are baroreceptors in the atria, right? And large pulmonary veins that monitor blood volume. And in the aortic arch, the carotid sinus and will monitor arterial pressure as well. So these receptors can modify blood pressure by manipulating the cardiac output. Alternatively, they can stimulate endocrine responses in the event of chronically low blood pressure. These will happen by triggering renin release, aldosterone, and antidiuretic hormone, right? On the other hand, high blood pressure is countered by releasing ANP and BNP hormones, okay? So let's talk about triggering thirst. So osmoreceptors are different from baroreceptors. The former, right, these baroreceptors are neurons in the thirst centers of the hypothalamus. So these neurons respond to changes, respond to changes in the osmolarity, the concentration of solute by shrinking or swelling, and these can trigger thirst, right? So thirst is an emergency response when need for water has not been anticipated. And there are two main triggers. You have cellular dehydration due to the ECF hypertonicity, and you have a big decrease in blood volume. So that's because angiotensin 2 is what triggers thirst, right? And so some thirst disorders, right? We have this hypodipsia. That's an inability to sense thirst. So usually related to lesions on the hypothalamic thirst centers. Polydipsia is excessive thirst, which may be normal if it accompanies conditions where you actually have water deficiencies, but it could also be abnormal. So true thirst occurs when we experience water loss and stops when it is regained, right? As during diarrhea, vomiting, diabetes, and with exercise. Okay, so there's these disorders, and then there's actual thirst, which is normal. Inappropriate thirst persists despite adequate hydration and is common in patients with congestive heart failure, chronic kidney disease, and compulsive water drinking is associated with many psychiatric conditions, let's say schizophrenia, okay? So let's look at disorders of antidiuretic hormone. So when water absorption is regulated by this ADH, right, this antidiarrhea hormone, this is also called vasopressin. Antidiuretic hormone is vasopressin. It is produced by neurons in the hypothalamus and stored in the posterior pituitary gland, right? So ADH is released in response to an increase in osmolarity, meaning a hypertonicity. And ADH release is bimodal. When you have small increases in osmolarity, this will cause a small increase in antidiuretic hormone, and this will help reabsorb water. When you have large decreases in blood volume, this will cause maximal increases in ADH along with the renin release. So diabetes, right, caused by deficiency of a decreased response in ADH. This is neurogenic diabetes, occurs due to the loss of neurons manufacturing this ADH. And nephrogenic diabetes occurs as tubular cells cannot respond to the ADH, right? So it could be neurogenic from the brain or nephrogenic from the nephrons, okay? This results in an inability to concentrate the urine, produces a diluted urine, and thirst is increased. The patients can remain hydrated as long as the water intake is inadequate. And difficulties arise when patients can't communicate the need for water or secure it, right? What are some of those manifestations? Patients with diabetes exhibit elevated heart rates, which may stem from the body's response to low body fluids. As a result of dehydration, your blood pressure may be low, while the peripheral constriction in response to dehydration could increase your blood pressure. The endocrine disruptions include catecholamine storms, so a lot of those catecholamines being released, lower cortisol levels, and the higher renin and aldosterone levels. So management, right? Ingestion of water to properly hydrate, pharmacological preparation of ADH, so desmopressin, and these thiazide diuretics, right, which are paradoxically trigger sodium and water reabsorption in diabetes, right? So this other one is called the syndrome of inappropriate antidiuretic hormone. This is an endocrine problem. So it occurs due to a failure of negative feedback mechanisms to inhibit the release of ADH. So continued ADH release, even after osmolarity is normal, results in fluid retention and hyponatremia. How do we treat this? We're gonna restrict fluid administration of diuretics and NaCl infusion due to the hyponatremia. What are some potential causes? Transient syndrome of inappropriate ADH results from stress, trauma, pain, surgery, and warm temperature. And recreational drugs and medication also could cause this. Chronic syndrome of inappropriate ADH results from lungs and other tumors that are capable of producing ADH, and CNS disorders also, tumors or head injuries. How do we know that this is happening? Signs and symptoms include you'll have concentrated urine, very strong, low serum osmolarity, and therefore low hematocrit, right? Sodium, and with no edema and endocrine and renal dysfunctions, right? So the disorders of sodium and water balance, right? Extracellular fluid volumes expand or will contract. So these disorders affect fluid volume in the ECF, causing them to expand or to contract. Recall, we said that 30% about of the water is stored in the ECF, in that interstitial compartment, right? And vascular compartments. Sodium imbalances cause movement of water between that ECF and intracellular fluid compartments, right? So over here you see low sodium concentration in the blood, not much. Low osmotic pressure and extracellular fluid. So water shifts out of the blood. More water shifts into the cell from low to high osmotic pressure, and the cells swell and their function decreases and they rupture, right? So isotonic fluid volume deficit, right? This is described as fluid loss with a proportional loss in electrolytes. So you have the same amount lost. Also referred to as hypovolemia. What causes this? So includes processes that lose water and electrolytes in isotonic proportions, loss of GI fluids, as in vomiting or diarrhea, kidney disease, right, related polyuria, and water and solutes over here. And how does it manifest? It includes thirst, weight loss, impaired temperature, regulation, increase in blood components like red blood cells, and decreases in tissue turgor, right? If prolonged, you'll decrease your blood pressure, and tachycardia could lead to hypovolemic shock. So now we have this, so in isotonic fluid volume deficits, you'll diagnose, can include fluid intake and output measurements, right? Although not always accurate. History of conditions with sodium and water retention rates, and measurements of blood pressure and heart rate. Venous refilling, right? So milk the dorsal vein on the hand towards the heart, Normally refills immediately, so that's one way of diagnosing. Capillary refilling, compress the fingernail for 5 seconds and the color normally returns in 1 to 2 seconds. And how do we treat it? Isotonic fluid replacement, right? Now, isotonic fluid volume excess, right? This describes as a proportional gain in fluid electrolytes, also referred to as hypervolemia. Causes include processes that gain water and electrolytes in isotonic proportions, most commonly by decreasing the sodium and water elimination by the kidneys. The disorders that influence sodium and water elimination: renal dysfunction, heart failure, liver failure, and any corticosteroid excess. Okay? So heart failure causes glomerular filtration rate to decrease. So fluid and fewer solutes are filtered to create your urine. Patients with liver failure, they show decreased renin activity in the blood, which decreases renal perfusion, which means decreased glomerular filtration rate. And the circulatory overload can occur in patients having received too much fluid via infusions or transfusions. And corticosteroid excess causes sodium retention. Those hormones like ALD, right, can act on the kidneys. So manifestations of this IFVE include weight gain, presence of edema. If pulmonary, also shortness of breath may occur, decreased hematocrit, and distended neck veins, right? You'll see over here, we see this distended neck vein. The diagnosis occurs by examining the patient's history and monitoring their weight and the presence of cardiovascular issues and edema. And the treatment will often include sodium-restricted diets, diuretic therapy, and transfusion of blood components.